Good morning, everyone. Mr. Rafael Guerrrero kindly agreed to give this presentation about innovation, technology, and imaging that we can use in cardiac surgery, and I believe we will use it in nearest future. So please, Rafael, thank you so much for agreeing.
Yeah. Can you hear me well, Oleg?
Yeah, it's absolutely fine.
Yeah, so I think that we chat with Oleg to see how can we mix a little bit the talks and to speak not pathologies and things for the future and what we're doing. And I thought one of the talks that probably many of you have already heard me talking about was about 3D printing, virtual reality, and I'm trying to condensate it in about 25 minutes. Essentially, just to see what's the journey, and because many of the people who are attending these meetings, the teaching, are from, starting in older age or only been for a few months. But the truth is, like, if we think about in cardiac, not just cardiac surgery, but I mean cardiology, cardiac surgery, or anything congenital, the truth is that one of the main problems that we have, or one of the challenges, is to visualize the organ, meaning to visualize the heart in a proper way, because it is not like you are walking around a chair or a table. You are able to walk around and to examine the table and the chair very well. And in other parts of the body, because it doesn't move, like the brain or the liver, you are able to use so many modalities, imaging modalities too. But that's not the case in cardiac. And many people have talked about virtual reality, simulation, 360 remote view. And what means everything, because people being introduced in the word, the denomination of virtual reality, when in truth what they've been doing is just like if you are in our theater, you can record 360 view of what we're doing, and that's no reality. Is a 360 view of what we of an operation in this case. Simulation, again, there is many applications in which are trying to say about simulation and virtual reality, but the reality is they are just models of digital models which they have created. You can put your goggles and look inside. But more for me was absolutely clinical in use. So it's good to have the models to explain to parents, for example, when we use our little application to show the parents the transposition of tetralogy, etc. But for us as clinicians, as cardiologists, as cardiac surgeons, and all the people involved in this, we really need to see what the real heart looks, because we know that every single VSD is different from the next one and the next one. And if they need to be treated with intervention or surgery, you need a specific or person-specific or personalized image of that patient or heart. There's no doubt that there's so many different generations. So I think that was Jasper who asked me to talk at the European meeting about the generation Y and cardiac surgery. And I was needed to find out what was generation Y. And definitely I did not fit in generation Y. There are people born in the 1980s and 90s. And probably they are already, some of them might be grandparents. So what we really probably talking in the next generation, which is the current, and most of this group of young people, not just young people, but all of us are using screens all the time. Very different education and from the past. So the objective for us today is just to talk about advanced imaging of the heart, probably touch a bit of 3D printing and congenital heart disease. And I'm going to expand a bit more of immersive technology and what means that. Because we talk a lot about immersive technology and we think that everybody has to be understanding this. And it's not totally true. And essentially, what are the clinical applications and the challenge of that? When you think about our operating theater now we have is with advanced imaging in cardiac anyway. So we have our hybrid theater and we have the other theater who have an integrated 360 view. Oops, not working. Just a second. So this was the first time that we used the hybrid, and then as you can see, Annette shouting because she was very excited. But yesterday they used the hybrid again, and what it gives you is like all different views of an angiogram and three CT dyno CT, which is not a perfect CT, but again it gives you an immediate view of the heart if we want to make decisions. It's far from perfect, but it's a lot better than before. But for us, the cardiac surgeon, that's normal, so we know that that's the heart. And I always like sometimes these pictures because I always use loops, and obviously we all the cardiac surgeons use loops, and we probably don't realize how small are the hearts until we see a photograph with our fingers next to the heart. And this is not a neonate, this is a bit bigger kid. And so in order to look inside, to look outside, it's just a lot of imagination that you need to have. And I don't mean just dreaming, but just really trying to imagine what's inside there, and a tetralogy, an arch, a truncus, the position of the BSD, etc., in order to repair. And I think that the better technology that we have to look inside the heart or outside the heart, the better surgeons that will become, or technicians, if you want to call it, and better outcomes we will have for the patients. The outcomes are phenomenal, but probably the outcomes, the mortality thing might not change, but it might enable us to do operations in a different way. The standard imaging, and this is just to recap and just to see where we come from, is X-ray, echoes, catheter angiogram, CT scan, and then reconstruction. And it's not new that if you show this to any, even somebody from medical school or any other specialty, they will not be able to interpret it. What's that? So they might be able to recognize that's the chest X-ray, but about the rest, forget it. And that's because we are so used to that, we can say that that's, I don't know, the PA, etc. But still, this is a two-dimensional view in a screen. And as a surgeon or intervention, he need to, for example, if we look into this area, and I'm trying to point here, you don't know if this band is going anterior, posterior, lateral 10 degrees in one way or 20 degrees in the other way, but it means a lot of imagination to trying to work out in which direction it's going. But obviously that improved with CT and MRI to give us a better view, and then reconstruction, in which give you, again, all right, so I don't know, the aorta and the arch is in this way, so the pulmonary artery is going one anterior, one posterior. But again, it doesn't give you an exact direction, 10 degrees and 20 degrees. And when you are with the heart stop, or in the catheter, when you are with trying to put dye and dye and dye, to trying to find out which direction, it's not perfect. So this is still a two-dimensional screen view for a surgeon or an intervention or for a cardiology, but it doesn't give you the full view of how it's supposed to look like in order for you to make the assessment, where do I cut, where do I put the stent, how do I reconnect these things. But the heart is obviously not a two-dimensional organ, and the procedures that we do are not two-dimensional, they're all in 3 dimensions. And I think that it's not that we forget that, but we just assume that that's normal, and probably it's not normal. So if you imagine somebody to take a photograph of a car and tell of the engine and go and fix it, and without nothing else of information, without looking inside. An engineer will have absolutely every single minuscule part in 3 dimensions view for them to look at. And they are not human bodies, obviously. So that means that you have to have a lot of mental imagery or visualization, and the brain have that. So when some part of our brains are designed to do that creativity. And when you have artists or painters, especially in the past, they were the photograph of the past. They were, because there was no cameras, obviously, and they used to replicate things amazingly. And that part of the brain is still with us, and we can imagine things in a way that it will help us to resolve problems. So in cases of heart surgery or intervention, I guess, on a personal level, I think that I've seen this, said this many times to the registrar, is I work out in my head the operation probably maybe 10 years ago. I used to do it 2 or 3 times before I was doing any operation, right from the beginning, right when I cut the skin, I go through the sternum, cannulate, etc. And I was just running the operation in my head from skin to skin, in all the dimensions possible and with all the possible pitfalls that I will find during the operation. So if I find, and if I open the sternum, and if I don't know, I go through the right ventricle, what will I do? So I have all these scenarios. And that comes from sports, because I used to do it, or I still do anything in sport. Like I plan my race or imagine my race all the time in my head to see if I'm winning or if I'm not winning, if the wind is coming in one direction or no, etc. So from the surgical point of view, I think that, I don't know, but I think that probably some surgeons do the same. I still do it, and it's quite useful. So that means that your brain has the capability to do that. But it would be great if we don't have to imagine 100% everything and to visualize. So the next step will be, we move into, okay, so will be probably 3D printing. That will be the closest that we can get into touching the heart that you are going to operate tomorrow, and look around and open it in the middle and see inside what it is. And when we present at the MDTs, we always, I don't know if you can hear us, the surgeon said, show me the 3D images, because that's natural for us. For us, the sagittal view or the coronal view is not natural to look, because we are not going to operate in that. What we want to see is the reconstruction, because that gives us exactly the idea how we are going to operate. So 3D printing resembled that, and the first one was, we call like 5-6 years ago, and we just tried, and that was at TAPVD, and we replicated the same size, and that was the first 3D printing that we did here. Can't remember, but probably easily 5-6 years ago. And as you can see, it's just exactly the same picture here, and which was great. And that's what encouraged me to, wow, we need to develop this more and more. And we get with a company to try, they didn't have a clue about 3D printing organs, because they were a 3D printing company who come from Kenya, and they were based in Kenya, and they were printing limbs for kids who were blown by their legs were blown by landmines. And they were just coming back to the UK because they were British, and we invited to the innovation place, and they learned together how to segmentate, how to get the heart, etc. Now they have expanded quite significantly. But as you remember, in the past, we used to have one of the guys sitting at our desk in our MDT, trying to look at the things, how can they help? That's going away a little bit, because it's become just now not that difficult to segmentate and to do 3D printing. And we have done, I don't know how many 3D printings. And I think that what is really nice is that it have spread, the majority of our consultants and trainees, etc., they want to do it. And during interesting cases, we cannot print everything because it's costly. And there is no, as usual, there is money for many things, but the NHS or the hospital doesn't think that this is important. I managed to get 50K, I think, from the Division of Surgery for not just cardiac, for cardiac orthopedics, to print all the organs that we want, or that we think that we need. But that need to be divided among all the different specialties. But we have printed several very interesting cases, like that sinus of Valsalva kid or the truncus, and that's help you, one, to show the parents what we are talking about in the real size, for training and education, and for decision making as well. So you can make decisions about, for complex CCTGA, and you can print in different materials. And we all have seen this. In the adult side, we print this one. It was quite an awkward case of a patient with some genetic malformation, and they came from Wolverhampton to the Liverpool Heart and Chest to the aortic team, and they couldn't get through the aorta at all, meaning through the chest to find the aorta. So I suggested let's 3D print the chest, let's 3D print the heart and the aorta, And at the end, we changed the approach, and we went to a anterolateral second space intercostal approach, and we cannulate peripherally, and we managed to find the aorta and did the aortic valve replacement together. But that was a very, very good application, not just for congenital and in general, how do you use the technology for solving problems? And this patient has been in 2 or 3 places in the UK, and they couldn't do it. And simulation and training as well. This is probably 2 or 3 years ago. This is Giuseppe, as you remember, one of our fellows, doing a tetralogy transannular patch. But it's more than anything, the texture is just so you can follow the steps and practice that. But the challenge are the anatomical details, so it's not perfect. So it's that the heart is at the top, and this is with a silicone, which is very, very expensive, and so it's not reproducible every day. But that's the one that looks more similar, and it's all about pixels. So how many pixels you want to call it, the technology will get better. The material is different because some materials are very hard. Silicone is soft, but it's ultra expensive, or I don't think it's affordable to do it on a regular basis. Funding is another problem because there is no funding for this. And I always was fighting, like in the same way that you have, Salim. Is Salim in the talk? No, isn't it? No. Oleg?
Yes, Rafael.
All right, you can hear me, yeah?
Yeah.
Okay, sorry, just. So the 3D printing challenge where funding is, so there is no funding for this. So instead of being so NHS organizations get paid for every single thing that you do, and that's called like a tariff. So if you put a chest drain, the tariff is, I don't know, EZB, whatever, and it's £300, and then the hospital get paid for that by the central NHS or Department of Health. So the same X-rays, echocardiograms, etc. But obviously 3D printing doesn't have a tariff, so there is no funding, central funding for this. So it's all charity work that we initially, you remember the first 2 or 3 years were charitable money that we used for the printing. And then after that, we have now convinced the Division of Surgery to fund a little bit of that. But that's not sustainable. Printing time is have gone down significantly. So I think that you have a dedicated printing in your hospital, that we were probably one of the first who have a dedicated printing or machines in our hospital with technicians that will reduce to less than 6 hours if you want, depending on the size of the printing that you want to do. So it's similar, like if you want to cook like a full chicken, like a 5 kilo or turkey, is different from, cooking in a microwave one bread or something like that. So if the size is important, how much you want to print, and the quality of the material, and then to become something routine and available. And I think that that's possible. So we are not printing as much as we were doing, and probably because we carry on, but I think that the more that we can do the collection of printing is good, because it will help us, one, to be the teaching and training sources for the future, for any trainee coming, or for us, because, all right, we have seen that before, how we tackle that problem. And obviously for simulation, it will be very important to carry on with this. But what else can you, I think that 3D printing, we've done it, we can do it, and I think that we will still do it in many cases. But more things than that is probably what I call immersive technology. And immersive technology, it comes from the gaming industry, and it came to using many other industries to use virtual reality in this case was the Virtual Engineer Center in Liverpool, and where they were designing the cockpit of the Bentley inside. And we got in touch with them and trying to do a project together. And that was 3 years ago, or 3.5 years ago, something like that. But immersion is a complicated thing. It's all physical, physics. But there is, if you want to call it, 3 flavors: virtual reality, augmented reality, and mixed reality. And virtual reality is like the one when you go in, when I show in the Innovation Center and you put the goggles and you cannot see anything so you're in a different world completely. So that's all virtual. And augmented reality or mixed reality when you mix both. So the HoloLens that we are trying the last few days is that you are walking around, you still can see everybody else around you, and you have holograms in front of you. So 2 different things and 2 different applications. Augmented reality is very new. Virtual reality has been for a while and is used quite a lot, probably the kids or people who play games, and they can immerse them. And that's why it's called immersive, because they immerse themselves in a completely different universe and they are completely separate. And whereas in augmented reality, which is fairly, relatively new technology, you are interacting with those things, but you can carry on with your normal life, having a coffee with your friend next to you, and you have the HoloLens in your face. And these are the main definitions of what means that. And you are going to hear in the cardiac center anyway, more and more of that about what's a hologram, what's a mixed reality, what's augmented reality. But the immersive technology means these 3, and augmented reality or mixed reality are probably about the same thing, if you want to call it. They are not that different, really. So in health, how do this happen in other industry? The answer is yes. So augmented reality and virtual reality, they use it in the building industry, in the nuclear industry. I don't know how much, but it's useful for them. Virtual reality in healthcare is being used primarily in mental health. What I'm talking is being used, are anecdotal hospitals who are doing this. It's not that everybody is like a routine process. So you'll have, like, I don't know, in Belfast, there was a little group of the psychologists trying to do virtual reality in healthcare to cure people, not cure, to get rid of phobias of high altitude phobias or high rise phobias. And again, simulation of VR when they are taking blood from you, and we were trying to use that in the outpatient clinic in Alderhay. But virtual reality, in the Formula One group, they use it all the time, etc. So it is happening. But again, it's either simulation or virtual reality, because a simulation is when you put models in front of you. That's not a real patient. It helps you to go through the processes. So if you want to have, and I think that will be very good for education and training, is like how we are going to put somebody on ECMO, and then you follow the process, and you put the goggles and you follow the process, and the people simulate and train. And that's a huge, I think they have significant application for that. In congenital heart disease, obviously, we were probably one of the first in the country, in the world, to do what we were doing, and which was, as you remember at the time, was like we reconstructed the tetralogy of Fallot case, and we were walking inside the heart. And we have this now for a few years, but it was difficult to progress from that because you have several limitations. One was that in order to reconstruct that heart, which is from a patient, it took days and days. And obviously, it's not my area of expertise or any of doctors' area of expertise. This is by engineers in virtual reality or software engineers who are able to do this digital transformation. And they haven't got a clue about the heart, so you needed to sit with them to try to make it something as similar as possible. But obviously, this is why I call it holoportation or teleportation, because what we're trying to do is, how can I travel inside the heart? My idea was, if I travel inside a heart, I can see in a tetralogy of Fallot, for example, where are the muscle bands and where are you supposed to be cutting. And then, so I'm not talking about for surgery, but in the future, if we develop endoscopic way of doing surgery without bypass, for example, we should be able to follow this holoportation and navigation inside the heart and exactly cut where we want to cut. So it's just thinking more beyond just that, you can see the heart inside. But that was just the beginning. For me, it was just right. So I think that we can do it, and now we can move forward from that. And then came augmented reality, which the main player for augmented reality really is Microsoft. So any other company, like they tell you is virtual reality. So the only one who came was a HoloLens 3 years ago or 2.5 years ago. And that was what I mean. So you are these guys with the building in the left-hand side. Obviously, this is just a video, a marketing video. But they are supposed to be interacting with each other, so they can see each other and they can see the building and look inside. This is from an educational Cleveland Clinic medical school. But again, it's a marketing video. So because when I actually inquired, it wasn't happening. But that was the aim, so that you are able to go with this to all the layers of the body. But again, it's just a model, which is good. But for us models are good, but we really need to have the real patient. The next ones are interactive holograms, and holograms are things that appear in front of you. And now 2 or 3 guys in the hospital have been using this now in the last few days. And now it's understanding what means a hologram. And you can manipulate them. And you have seen Fu and myself and just sometimes walking around in the office and moving our finger from one place to another. And it's just we are manipulating these holograms. And the idea is how can we use them as an image with a particular patient. And for me, the idea was, okay, so now I can, if I'm operating, how can I overimpose that on the heart that we am operating or doing an intervention, and it gives me straight away the 3D image that I have in my head in live, so that is reproducible. So if I am a new surgeon, which I don't have the experience to see all these things, I can do, accelerate the learning curve, if you want to call it. And this is the HoloLens number ones, which are comparing with the next new ones are like, a lot more heavier, and the view is a bit narrow, but it's the usual, the technology just advanced. And these have like sensors that you can talk to, it's voice activated, transparent lens, and that's how you can communicate with the rest. And have the unit have an holographic processing unit and a spatial sound, so it will block the sound, the noise around you. Why is this? Because in many places this is used, for example, in huge factories where the noise inside is that horrific noise. So the people need to communicate with HoloLens by voice activated, so the HoloLens block all the noise outside. There is good things for them. For us, it's not great, but we're trying to get through that, because if we are interacting with a patient, might be that they don't hear us. Sorry, we can hear them, but the people who are following us in the HoloLens might not hear them very well. And we did a piece of work with them, and it was, all over the place, where we, Olderhead, were doing in all different languages, including in Chinese, in Japanese, etc. But that's Microsoft for you. Microsoft is a global company, and if they like something, they will just reproduce it everywhere. So we have progressed from what we were trying to do our first visit to the Virtual Engineer Center, how can I play with the ribs and all that, to the next group in which we were, this is 2017, because it was in Dubai, actually. And we were presenting this in the Arab Health. And then the next one, trying the HoloLens. That's virtual reality, trying the HoloLens here. But we're just trying. The truth is that it was just more that what I have in my head for the future than what was happening at the time. So the applications is obviously, advanced visualization, planning and simulation, a lot of simulation. And I think that, and I add the intervention because I think that for intervention will be phenomenal training to do this using augmented reality. And obviously for patient communication. And just recently, and I add this because it's infection control, because now the drive for all this is COVID. So how can we use augmented reality, mixed reality for infection control, in this case, COVID-19, when you need to limit the amount of people, keeping the distance of 2 meters, limited amount of people in a work round, limited the use of PPE, etc. And that's how we found another part that we can work. And we are working with Imperial College in London to do a multi-center trial in trying to see if this is workable, not workable, but all the advantage and disadvantage. Challenge cost and funding, I don't think that is huge. The hospital, just to let you know, I think that they have bought 4 or 5 robots, those iPads on wheels that are in 1C neonatal unit, each one 40 to 50 grand. But when you ask them to fund 2,000 pounds of thing, they say that no. So then we just got it from other sources. But I don't think it's terribly expensive, and you can save a lot of money. From our point of view, it will give you hopefully in the future, because we shouldn't look what's happening now. This is just the beginning of something. So we should look like how we wanted to develop in 5-10 years time. And the visualization will be pretty good, I think. That it hopefully will be more mobile, which is more mobile now, so we can walk around. Even the batteries are lasting for 6-7 hours. And the processing speed, this is still a problem, because to process the hearts, it will take time. However, when we're talking about virtual reality, so when we're doing with the Virtual Engineer Center, that was take weeks. Now the aim is trying, how can we get the image from the care stream into the HoloLens, so you don't waste time, so you don't need to reinvent that. So you can travel inside the heart by just transferring the image into the HoloLens. And we're planning to do a piece of work with FU and other groups to see if we can make that happen. And that will change significantly the way that we will visualize the heart. Of course, the benefits are, it will improve outcomes in some time, and we will reduce costs, or will become cost effective. I'm sure that the work rounds will become quicker and more efficient if I don't know, maybe if we use that. And we definitely will reduce the number of use of PPE, definitely, if we use it. Having said that, COVID is not going to stay with us forever. It's going to stay for us probably for a year or so. So we need to learn another ways. But teaching, training remotely, it will be multiple applications. And I wanted to give this talk because I saw this is a moment that all of you will have some ideas about how can I use it in different ways. And and HoloLens 2, which and remote assist is to use anytime, anywhere. And we are planning to go trying to put a clip together of the things that we've been doing in the last week or so, or 2 weeks, so that everybody can witness what we're thinking to do with the work rounds. But the 3 main things that we tried, which I don't know if I will be able to show. Give me 2 seconds. Can you see that, Oleg? Oleg?
Yes, absolutely fine. Yeah, we can see that.
You can see it. So we were just trying. That's a hologram, and they were in the cath lab doing the PDA stent, and it just saw. This is what Fu can see with the HoloLens. And the other one is. But this is in our. So that's Arul is holding the HoloLens in his hand, in his head, and he's manipulating the reconstruction for the PDA stent with holograms, moving it around. And And the aim was
for him
to
do with that angio?
I can see that angio here, the CT, that's who is trying to show now.
Which angle would you like me to show?
Excellent, yeah. Sorry. Okay, if you can turn it to the left side, please.
Go straight left or what angle?
So the aim was to overimpose. So the aim was to overimpose the image into the heart, so you can see in which direction they are going to put the stent also. But that was, we were just testing, and that will get a lot better. It is great. It's probably the first time that Arul was wearing the HoloLens, but then we try, and so it worked fine, and this is going to get better and better. I didn't need to be there. I could be at home and be watching that straight away from the HoloLens. and the other big project which was the primary project, was to do the world rounds using HoloLens. And in this way is the world rounds in one city is about 5 to 6 people walking around with 2 or 3 computers. I don't do the world rounds, so I cannot even decide, if it's a good process or not. But of course it works for our service. But how can we make it more efficient? And more important is, if we start getting infected patients, etc., how can we reduce the amount of people, 1, in contact with that infected patient, and 2, reduce the amount of people next to each other to reduce contact and so on. So it was one, again, we just tested yesterday and the day before, and one of Samantha, I think is one of the SHO, was telling the registrar what was in the Meditech, and he could see a hologram with the Medicate in front of him, so he can see, all right, so the urease X and the X-ray looks like that. We have tests with echocardiograms, etc. So we're probably going to plan a very much better, not better, but sorry, this is just testing how it's going to work. But I think that it's going to be phenomenal. The benefit that you can see is that the world round become more efficient, because each person have a task. They don't need to be in the ward, they can be in an office. Only one person look around, they can interact with the patients, the families, and you could see all that, which I haven't got the video with me today because I didn't have time to download it. But that's the beginning of how we are using this. Here is when we're doing that little kit with COVID in the transposition. So Fu was communicating with Mike and showing him the anatomy, and you can use it with visor, you can use it with the mask and the whole PPE process, the equipment as well. So we in Alderhay now, we are probably one of definitely the first children's hospital in the country who is doing that, and probably in the world. And among adults and pediatric hospitals is probably Imperial and ourselves. Imperial have a lot of money and they have a lot of COVID patients, so they were starting to do that. But we are working together because the only way is to collaborate with each other. So I think that for the next generation and for us probably is that they are going to get education and training anytime, anywhere. So they are not going to be in a classroom. They will be at home and open their tablets, and they will be able to revise like they are doing now, all the universities, and anywhere as well. So, and could be any time of the day. In fact, they were asking me if we can get, and we can talk about this, like, undergraduate students from Imperial coming and virtually see what we're doing in theater or in the cath lab or in the world round. And for them will be amazing because they don't have that facility. And that's, so the future is, as I always told you, that's our heart center. It's going to be built there. Or that's our dream anyway. Okay, Oleg, I think that's it.
Thank you, Rafael. It was really impressive, especially like implementation of these technologies right now. and this is a really good time, I think, to talk about that and to push it forward, especially now when we have this infection problem. So, do you think we can do more except word rounds? I mean, like operate even in this with our loops or not in theater?
I think that will be. I think that will be one. I don't think that will be necessary to use it all the time at the moment, but probably will be difficult or the compatibility between using loops and the HoloLens at the same time. And I try one. Well, you can use it work with glasses. That's absolutely normal. But because our loops are so big that it will be difficult. And second, you see the holograms massively and there is reflection of the glasses. So the answer to that is probably loops and HoloLens or any kind of those type of lens are probably not compatible. But if you think in the future, it's likely that we will, I think that we will operate with screens or another type of screen reflected into you rather than loops. But that's at the moment, it's just you can wear it like hypothetically you want to show, and I always think like that. So if I'm opening a case and it's something very strange, I just put the HoloLens, phone my colleagues and the cardiologist and say, look, that's what I found. They don't need to come into theater, and they will be, and the view is perfect as we did the other day, and they can see exactly what I found, and they say, well, and have a little MDT. Without they might be at home, or they might be in their office, or they might be somewhere else. And I think that that's one of the good applications at the moment. In the future, will be different.
Thank you. Any other questions from auditorium?
They are all asleep, Oleg.
They're just impressed, I think.
Nah.
we muted all, and then we forgotten. No, it's excellent. I mean, you can see that's the future, isn't it? Quite a lot of things, much more in detail, and when you need it in the theater. That's very futuristic. Sorry, we probably everybody muted themselves, but
yeah.
Can you hear me, Raf?
Yeah.
Very, very nice talk. That was really quite interesting in terms of all the different applications. I have seen some of these applications being used in Italy as well. I think their engineering department, particularly in the north part of Italy, is quite advanced. And when I initially was searching for a fellowship, I'd gone for an attachment for a couple of weeks to San Donato. I know at that time they were using a lot of virtual reality to plan some really complex procedures, and they didn't have the HoloLens at the time, but they had a screen which they were projecting some really complex procedures on, which could be seen live at the same time when you're doing the procedures. So I know there's a lot of application out there, and then in a couple of other conferences that I've been there, I think Fu might have been in one of them, but particularly when you go to the Italian conferences, there are a couple of companies which are doing virtual reality procedure planning, and it might be worth for us to get in touch with them and see how we can apply their knowledge and technology to what we're doing as well. Because I think they've been doing it for a couple of years, but not particularly in HoloLens, but more on screens and everything.
You know, that would be very useful. I think that the more than we can involve other groups, the better. Because we are all, you know, we don't know a lot about the technicalities of this, and it's just to hear what they're doing and see if we can work together. I think that would be very useful.
Okay, there you go.
But for for the world rounds and all that, that's a very topical situation now. Of with COVID-19 in one of the main problems now, we cannot go back to normal in older age because there is not enough mask, PPE, and you can see even us in the intensive care world round, we have reduced significantly the amount of people going to the world round from cardiac surgery. It's a great world round in which we used to be all there. But we hopefully by next week we'll try to implement this in a couple of weeks. So we'll come participate all in the world round, even if you are at home. You will be able to see your patients. You will be able to see everything. But and I think that will be quite useful for everyone.
Thank you very much, Rafael, for this brilliant presentation. I think every time after main topic of disease, we can do this invited lecture about different stuff that around cardiac surgery, not exactly cardiac surgery, to push forward our thoughts and dreams. I mean, in direction of research and innovation. What do you think?
Yeah, I think that's a great idea. And we, with teams, what I was telling you, Oleg, and probably the rest, we probably can have external somebody from abroad or somewhere else to talk about it. Like if we were, I don't know, if we want to talk about, let's see, I don't know, tricuspid valve repair, and we buy some of our colleagues who are more experts in doing that, or somebody from abroad, or considering time difference. But I think that we can use this opportunity to expand, the heart talks to either inside our hospital or to do it more widely. I spoke with the chief of ITU in Toronto about something else. We're talking about something else, and I said, well, would you be all right if we invite you for a talk? And he said, of course it will be, like, because it's so easy. In the same way that I've done it from home, for them will be, the time difference is a problem. But I think that if we think about topics like that, and we all have contacts abroad, and if you think that that can be useful, we can expand our our heart talks to more, not just local, but international as well. And second is, I don't know how you think, guys, is to expand the audience to invite. Initially, we are going to plan to invite some of the other surgical trainees, congenital surgical trainees, mainly, especially from the north first. And if that works all right, we can invite people from other areas.
Yeah, I think that would be great. And actually, we can use this HoloLens in our heart talks as well, especially if it's like a surgical topic, and we can show live case at some point. Yeah.
I think that's it. They are ours, so they are from the cardiac, surgical, and cardiology department, so we can use them. They belong to us.
Great. Thank you, Rafael. Thank you, everybody.
Thanks.
See you next week on Wednesday at 9.
Okay. Thanks, everyone.
Thank you all.
Thank you, Rafael.
Thank you.